first co-instructor, our first speaker, Dr. Ashish Markan. And Ashish Markan has done his post-graduation at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi. And he did his MCH in Vitreoretina at PGI Chandigarh. And currently he is working as a consultant Vitreoretina at I7 Hospitals, New Delhi. And he'll be speaking on introduction. He'll be giving us a brief introduction to ocular injuries. So over to you, Dr. Ashish.
Thank you, Dr. Devesh. A very good morning to all. So today I'll be talking about ocular trauma, just a basic introduction. So you know that ocular trauma is one of the leading causes for reversible as well as irreversible loss of visual function. It is important to promptly recognize, evaluate and manage ocular trauma. So when we look at ocular trauma, there are various aspects where the injury can happen. It can either be globe injury, could be optic nerve head injury, or it could be an adnexal injury. So ocular injuries are basically classified broadly into two categories, mechanical or non-mechanical. Mechanical can then further be classified as globe injuries or adnexal injuries, and non-mechanical into chemical, thermal, electrical or radiation-induced injuries. So when we talk about the setting of injury, like the patients who commonly present to us in the OPD, the most common site of injury while are either during the daily activities, road traffic accidents, sports injury, assault, agricultural activities, or industrial work-based activities. So it was very important to actually classify these ocular injuries and give them a terminology. So it was in 1996 that Birmingham Eye Trauma Terminology System, which is shortly known as BETS classification, was introduced. And according to that, eye wall is defined as sclera as well as cornea. And the closed globe injury is when there is a partial thickness injury to the eye wall, and open globe injury is when there is a full thickness injury to the eye wall. The closed globe injury can further be divided into contusion and lamellar laceration, whereas open globe injury can be divided into rupture, laceration. And then laceration can further be divided into penetrating injuries, perforating injuries, and intraocular foreign bodies. Rupture is a full thickness wound of the eyeball which is caused by a blunt object and is due to an inside out force. Usually happens at weak areas of the eyeball. Laceration is a full thickness wound of the eyeball which is due to the sharp object and is an outside in force. Penetrating injury is a single entrance wound due to a sharp object. Intraocular foreign body is when there is an intraocular foreign body inside the eye, either in the anterior segment or in the posterior segment or impacted in the retina. And a perforating injury has a separate entry and an exit wound. The injury is caused by a sharp object. So now, once we have learned about the terminology or the basic nomenclature, now it is important to classify ocular trauma. It is done on basis of the type of injury, the grade of visual acuity, depending upon the pupillary status, whether RAPD is present or is absent, and about the zone of injury. Amongst these, grade and pupillary reactions are the most important prognostic factors. So when we talk about closed globe injuries, so type of injuries, either it could be a contusion, type A, type B is lamellar laceration, type C is superficial foreign body, and type D is mixed. Talking about the zone of injury, which is very important, zone 1 is when the injury is happening just in the bulbar conjunctiva, sclera or cornea. Zone 2 is when it involves the anterior segment or the pars pliccata, and zone 3 is when the posterior segment is involved. Then we also look at the pupillary reactions and grade the visual acuity. Similarly, when we do classification for the open globe injury, there are again 5 types of open globe injuries. Type A is rupture, type B is penetrating injuries, type C is intraocular foreign bodies, type D is perforating injuries, and type E is mixed. Talking about the zone of injuries, it could either be zone 1, which involves cornea and limbus, zone 2, which involves limbus to 5 millimeters posterior to the sclera. This 5 millimeter figure is very important because after this the aura starts, and anything which causes injury in the zone 3 likely to cause injury to the retinal structures. So zone 3 is posterior to 5 millimeters from the limbus. Then we again grade it similarly as per visual acuity and whether the pupillary reaction RAPD is present or is absent. Now also it is important to prognosticate a case. So it is done on basis of various variables. It could either be functional variables or anatomical variables. Functional variables is an initial visual acuity, and anatomical include whether there is rupture, endophthalmitis, perforating injury, retinal detachment, or presence of afferent pupillary defect. So all of these variables have been given some score, and the visual acuity, better the score, And then either of these is present if globe rupture, endophthalmitis, perforating injuries, retinal detachment, RAPD, they are given a negative score. At the end, and we compute the entire score and we give a raw sum score. And depending upon that, you can actually estimate the final visual outcomes. Now, what is the mechanism of closed globe injuries? So it is basically based on coop counter coop injury. Coop injury means that the impact is happening at just at the site of impact, or the injury is happening at the site of impact, and counter coop is basically it happens directly opposite to the side where the impact has happened, and it is due to the shock waves which are traveling from the site of impact to the posterior pole. So there is actually a decompression, and then the globe, there is a compression and there is a decompression. During the decompression, the globe rebounds more than its normal shape and can cause various contusion injuries inside the eye. So some of them are like subconjunctival hemorrhage, hyphema, angle recession, iridodialysis, cyclodialysis, sphincter tear, rosette cataract, zonular dialysis, retinal dialysis, Berlin's edema, vitreous hemorrhage. So this is very important when we talk about rings of trauma. So 7 rings of trauma are actually circumferentially oriented ocular structures anterior to the equator, which are classically damaged following a closed globe injury due to coop contra coop injury. And these are, we have already discussed them. So these are sphincter tears, iridodialysis, angle recession, cyclodialysis, clefts, trabecular meshwork tears, zonular dialysis leading to lens subluxations, and retinal dialysis ultimately leading to retinal detachments. Lamellar lacerations, we have already told that they are superficial injuries due to sharp object, but we need to do a Siddle's test to rule out any full thickness defects. Superficial foreign bodies are the foreign bodies which are lodged just on the ocular surface or in the fornix or the bulbar conjunctivas. Rupture is an inside-out force due to a blunt object. The most common locations are the weak locations like limbus, previous surgical wounds, or physiological scleral thinning parallel to or underneath the insertion of the recti muscles. So either the rupture could be overt. You can actually see there's a rupture, there's a prolapse of the intraocular tissues. But there are cases where there is an occult rupture, and it is very important in an emergency to basically rule out and look for the signs of occult rupture, which are either the conjunctiva is very boggy or chymosed. There could be subluxation of the lens in the subconjunctival space. IOP could be low. The pupil could be centric or peaking. And there could be vitreous hemorrhage or vitreous strands pointing to ocular coats, basically suggestive of vitreous incarceration. So penetrating injuries are further, it could either be corneoscleral without any prolapse, it could be scleral without any prolapse, then it could be a corneal laceration with iris prolapse, or it could be a scleral laceration with a ciliary or vitreous prolapse. So intraocular foreign bodies, they could be either reactive or non-reactive. So further they are divided as metallic, non-metallic, and metallic are iron, copper, which are more commonly seen and could lead to sidrosis. So it is also important to rule out occult intraocular foreign bodies and actually look at the signs of occult intraocular foreign bodies. These could be iris holes. There could be signs of toxicity like sidrosis. You can actually see brownish discoloration of the lens, of the cornea, etc. So lastly, as we already discussed, perforating injuries are when there is both entrance and the exit wound, and the exit wound usually closes by fibrosis within 5 to 7 days. So to summarize, ocular trauma is an important cause of blindness. Proper terminology and classification system should be followed for uniform nomenclature and accurate transmission of data. Open and closed globe injuries have different pathomechanics, and prompt recognition and early intervention limits the ocular morbidity. Thank you.
So, thank you, Dr. Ashish. You have given a wonderful overview of the terminology system as well as the Ocular Trauma Society scoring system, which is important for prognostication of ocular injuries. And you have very well highlighted the importance of identifying the subtle signs which are suggestive of occult rupture or occult open globe injuries. So if there are any questions from the delegates they want to ask, or if there are suggestions from other panelists.
I would I have not highlighted that point, but I would just suggest that whenever you find a patient of ocular trauma in your emergency, it is always important to get an X-ray orbit, even if it is an open globe injury or a closed globe injury. So open globe injury, you'll be able to find if there's an intraocular foreign body, and if it is a closed globe injury, so you'll be able to rule out whether there is some bony fractures or there is some globe subluxation, which is very important to prognosticate a case and actually tell the patient before you start intervening in that case.
So yes, other than the orbital fractures, sometimes the open globe injuries may be self-sealed, and the point of entry may not be appreciated on slit lamp examination also. So there can be intraocular foreign bodies which may be missed and which could lead to problems in the future.